Hello everyone, I am excited to discuss yet another new drug class for the treatment of type 2 diabetes. I have nothing to disclose. As a review, in healthy individuals, as shown on the graph on the left, when oral glucose is ingested, it causes a more robust insulin secretion, represented by the black line, compared to IV glucose, represented by the red line. This difference is known as the incretin effect, which is mediated by two gut hormones, GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide. In patients with type 2 diabetes, as shown in the graph on the right, this effect is reduced. Tirzepatide offers a novel mechanism of action. It builds upon the GLP-1's mechanism of action and acts upon two receptors, not only GLP-1, but GIP as well. However, I do want to point out at this time, we do not completely understand which receptor agonism, GLP-1 or GIP, is responsible for the effectiveness of tirzepatide. Given the unknown mechanism of action, I like this graphic because it shows where some of the synergy exists between GLP-1 in red and GIP in blue. Starting from the left, we know lots of GIP receptors are on adipose tissue. The drug manufacturer actually found liver fat was decreased by 50%. Trials are already underway, so we may see tirzepatide eventually being used in the treatment of non-alcoholic fatty liver disease. Moving down the graphic, we are all very familiar with how GLP-1 works in the CNS to reduce hunger. However, while we know there are GIP receptors in the brain, we do not know yet what the impact on hunger will be. Both GLP-1 and GIP act in the pancreas to increase insulin secretion, thereby lowering glucose. However, their effect on glucagon is opposite, and the impact of this opposition remains to be seen. I do want to point out one location where the hormones do not overlap in the stomach. GIP does not affect gastric emptying, which I think is good, as none of my patients would be excited about additive GI effects. Finally, on the purple, which is on the right, the actions of tirzepatide are summarized in patients with type 2 diabetes. Another caveat to tirzepatide I want to point out is in regards to pharmacodynamics, specifically around the delay in gastric emptying. With tirzepatide, as also seen with dulaglutide, the effect on gastric emptying is largest after the first dose, and then subsides over time. This is an important counseling point as when discussing side effects with patients, as we do see often clinically GI side effects wane, roughly 2 to 3 weeks after starting or after a dose increase. At this time, tirzepatide is only FDA indicated for type 2 diabetes as an adjunct to diet and exercise. In April, you may have seen the SURMOUNT-2 data. Participants in this trial were adults with BMIs of 27 or higher and A1Cs of 7 to 10% who received tirzepatide for chronic weight management compared to placebo. Participants lost up to 34 pounds over 72 weeks in the one arm taking the max dose of tirzepatide 15 milligram. Labeling for a new weight loss obesity indication has been submitted to the FDA with an anticipated response expected by the end of the year. I want to point out here is I was actually shocked that Lilly didn't do more to differentiate these tirzepatide pens from others. For those of you that are familiar with Trulicity pens, these pens look nearly identical. I do worry about the impact on medication safety, especially if multiple family members of the same household have type 2 diabetes and are taking GLP-1s and tirzepatide. The only distinguishing feature of the tirzepatide pen as compared to the dulaglutide pen is the injection button that's at the top. In the case of tirzepatide, it's purple, as seen in this image, compared to Trulicity pens, which have a green injection button. Tirzepatide is dosed weekly, and the titration schedule to the max dose of 15 milligrams takes a whopping 6 months. Patients are started at a dose of 2.5 milligrams, which is a priming dose, so it does not have much glycemic impact, if any. And after 4 weeks, the dose is increased to 5 milligrams weekly. From there, if a patient is still in need of glycemic control, the dose can be increased by 2.5 milligrams every 4 weeks, again up to the max of 15 milligrams weekly. Keep in mind, if a patient is having tolerance issues between these dosing intervals, it's fine to extend the dosing interval. The Tirzepatide pen is a single-dose pen, just like dulaglutide, and this feature makes prescribing Tirzepatide a little tricky given the lengthy titration. I would recommend the use of local pharmacies for a 30-day supply until the maintenance dose is achieved before sending to mail order, despite some payers offering patients discounted copays. Hence, I encourage shared decision-making, talking to your patients as to why you prefer the use of local pharmacies when first starting this drug. Finally, Tirzepatide, like dulaglutide, is an auto-injector, so there are no additional prescriptions for pen needles required. In the era of GLP shortages, and in this case potentially switching to a new drug, I want to draw your attention to a new MCT2D resource, our switching tool. If switching patients from a GLP to Tirzepatide, I would go from patients' prior GLP dose straight to 5 milligrams, skipping that 2.5 milligram priming dose. Otherwise, there could be a loss of glycemic control that could occur in that month. Priming doses on this chart are denoted by a star. I would like to take a brief moment to comment on switching between GLPs. I practice conservatively. When it comes to GLPs and their side effects, if I have a patient with prior significant history of GI side effects, I do not always go to the listed equivalent dose seen here on this slide. Typically, I would start at the next lower equivalent dose, and if the patient is tolerating the new GLP after a few weeks, then I would go ahead and titrate to the original equivalent dose. This is yet another example of shared decision-making with your patient. No surprises here, Tirzepatide carries similar side effects and has discontinue rates that are similar to the GLPs, with GI side effects predominating. So now let's take a look into the trials. Here I compared monotherapy trials, Award 3 with dulaglutide, Sustain 1 with semaglutide, and Surpass 1, which was with Tirzepatide, having participants who were drug naive. And in all of these trials, the numbers on the slide are reflective of the maximum doses. I also included Award 11 and Sustain Forte, and these were trials for expanded dosing for dulaglutide and semaglutide respectively. These two trials were not monotherapy trials. Participants in these two trials were on baseline meds of metformin for Award 11 and metformin and sulfonylureas in 50% of patients for Sustain Forte. As you can see, nausea and diarrhea are most common with Tirzepatide, and around 10 to 20% of participants reporting it, while vomiting and constipation occurred in less than 10% of patients. So now let's go ahead and take a look at the discontinuation rates looking at the same trials. You see discontinuation rates due to GI side effects are fairly similar. Differences that you see below are likely not clinically significant. The starred values under Award 11 denote all side effects rather than just GI side effects as you see in the other trials. The other interesting point to note is, as you can see in the second row, the cause for discontinuation is similar across the board. Further, when you looked at each of the bolded side effects individually, none of them were reported over 2%. As a diabetes clinician, one of my main priorities is for patients to avoid hypoglycemia. When looking at Tirzepatide as monotherapy, this yellow box should not be surprising. If you recall, Tirzepatide's mechanism of action is glucose-dependent insulin secretion. But of course, patients are rarely on only one medication. Now let's look at hypoglycemia rates with Tirzepatide is added to other medications. In the Surpass 4 trial, Tirzepatide was added to patients with type 2 diabetes and high-risk ASCVD. They were treated with any combination of either metformin, nearly all participants, 50% were on sulfonylureas, and 25% were on SGLT2s, compared to adding glargine to these oral medications. Those receiving tirzepatide were started at 2.5 milligrams weekly, then titrated to the 3 doses shown on the slide. Those receiving glargine were titrated until participants' blood sugar was less than 100 milligrams per deciliter. We see the highest rates of hypoglycemia when either tirzepatide or glargine is added to sulfonylurea, compared to the other oral meds, metformin and SGLT2s. And in both cases of oral meds, hypoglycemia rates with tirzepatide were lower as compared to glargine. Now moving to the bottom of the chart. In SURPASS-5, tirzepatide is compared to placebo in participants who were already on baseline glargine, around 30 units, and 83% of participants were also taking metformin at a dose of at least 1,500 milligrams daily. While hypoglycemia was low and similar to placebo, we do see hypoglycemia when tirzepatide is added to insulin, versus what we saw on the last slide with 0 incidence. So in summary, anticipate hypoglycemia when tirzepatide is added to basal insulin or sulfonylureas. So next, we're going to move to discussing when and how much you should decrease insulin when adding tirzepatide. Here again is the data from SURPASS-5. Recall participants were on about 30 units of glargine and most were on metformin. At randomization, if participants' A1C was 8% or less, their insulin was automatically reduced by 20%. Keep in mind, participants were started on 2.5 milligrams at randomization. So this is my one criticism of the study, reducing the insulin dose prior to the use of a therapeutic dose. During the study, if participants in either group had fastings less than 100, their insulin was reduced by 10%. As you can see in the yellow boxes, participants with lower A1Cs had insulin dose adjustments around a dose of tirzepatide of 10 milligrams, while participants with higher A1Cs saw their insulin doses adjusted at a tirzepatide dose of 15 milligrams. In summary, most patients did not require major insulin adjustments. Patients should be told to monitor their blood glucose closely when adding tirzepatide to insulin. As clinicians, we should anticipate lowering insulin doses around a 10 milligram dose of tirzepatide and consider preemptively lowering if a patient's A1C is at or below 8%. Using the SURPASS-5 findings and combining insulin recommendations, including prandial, from an article by Liz Van Drill and colleagues on deprescribing insulin when adding GLPs, we can offer the following recommendations. When adding tirzepatide to basal insulin, consider the patient's A1C first. Then, if patient's A1C is at or less than 8%, consider up to a 20% dose reduction of basal insulin after patient reaches the 5 milligram dose of tirzepatide. If patient's A1C is above 8%, there is no preemptive dose decrease required. It is important to reassess the need for insulin adjustments after each dose increase of tirzepatide. When adding tirzepatide to a patient that is also on prandial insulin, you first want to consider the patient's risk for hypoglycemia, such as frailty, age, diet, carb changes, or perhaps if they have decreased food intake. Next, consider the patient's prandial dose. If they're on a low prandial dose, typically defined as less than 10 units per dose, you might want to consider discontinuation of that prandial insulin. For those patients on higher doses, they may benefit from a 50% reduction in their prandial insulin. When adding tirzepatide to sulfonylureas, consider a cross taper if A1C is on the higher side, or discontinuation. I do want to point out one important drug-drug interaction that we do not see with GLPs, but is included on the tirzepatide labeling. Tirzepatide reduces bioavailability of oral contraceptives. Per package labeling, A1C was reduced by 20% and Cmax was reduced by 50 to 60%. The mechanism for this interaction with tirzepatide is not understood. Thus, this is a unique patient consideration when thinking about prescribing tirzepatide. It is recommended to address intentions for pregnancy prior to prescribing. The manufacturer recommends using a barrier method for 4 weeks after starting this medication and after each dose adjustment. Alternatively, patients could talk to their PCP about switching to a non-oral contraceptive during titration. Switching gears a bit, I was asked about alcohol intolerance with GLPs a couple months ago. At the time, I hadn't heard about this, but upon going to the literature, I couldn't find much, not even any case reports. But then there were a lot of stories online, and I listed some of the patient descriptions here on the slide, and even a segment on the Today Show. In reflecting on these stories, we do know that GLP receptors are expressed in areas of the brain that are involved in reward and addiction. So it is possible from a mechanistic explanation that this is a potential impact for some of our patients. After a little bit more digging, I did find 2 clinical trials currently investigating tirzepatide's effect on alcohol intake in patients with addiction. So I suspect more is yet to come. Perhaps when discussing social history in those in your patients that report frequent alcohol use, you might want to inform them of this possibility. Yet another similarity of tirzepatide to GLPs is having the same box warning about thyroid C-cell tumors. The approach is the same as what we do with GLP-1s. You screen your patients for self or family history of medullary thyroid carcinoma or MEN2. I would like to call attention to another MCT2D tool, this time a patient-facing tool. The request came from one of our MCT2D nephrologists for a one-pager to address patient concerns that are often encountered in practice regarding SGLT2s and GLPs. So this resource that we created for each class covers what truly are the most common side effects, along with mitigating strategies for patients. Given that these meds have benefits beyond glucose lowering, it also highlights the cardiorenal benefits. And finally, each document has QR codes at the bottom, which links to our MCT2D resources for cost savings for these particular classes. Now that we've covered side effects, let's switch to the exciting part, the outcomes of tirzepatide. Again, using the same GLP-1 comparator trials, AWARD 11 and SUSTAIN Forte, which had background meds of metformin and sulfonylureas previously discussed, we're now going to compare them to SURPASS 2, where participants were on tirzepatide and at least 1,500 milligrams of metformin. In the top yellow box, you can see the A1C reduction with semaglutide at 2 milligrams is clinically about the same as tirzepatide. It's when we start to look at weight reduction, highlighted in the bottom yellow box. This is where tirzepatide really pulls away. At tirzepatide 10 milligrams weekly, it has nearly twice the weight loss compared to dulaglutide and semaglutide. For my patients who have been tirelessly working on lifestyle improvements, these results are extremely motivating and potentially game-changing. One of the most impressive things I see here is highlighted in the teal box. 80% of participants in SURPASS 2 achieved more than a 5% weight loss. Over 50% achieved more than a 10% weight loss. And over a third of participants achieved greater than a 15% weight loss, which has not been seen in any of the GLP trials. It's also important to keep in mind that the greater than 15% weight loss seen here is encroaching on the results seen following bariatric surgery, which is usually around 25 to 35% weight loss. Despite all these positive tirzepatide outcomes just discussed, unknowns do remain. We know that without a doubt, most GLP-1s have a very positive role in cardiovascular outcomes. But not all GLPs have these proven cardiovascular outcomes. The cardiovascular trial for tirzepatide, SURPASS CVOT, is expected to conclude next fall in 2024. I think that this should give us a little pause, that until we have the data to support tirzepatide actually having similar cardiovascular risk reduction, we consider who are the best patients to benefit from this drug at this time. Moving on to cost, which is one of the biggest challenges we face in primary care, surprisingly, tirzepatide has pretty good coverage in Michigan, as seen by the green boxes. As of late spring, MCT2D received the following updates, shown in the right column with the yellow boxes. The yellow circles, which are actually clocks in these boxes, are used to represent plans having an auto look-back prior authorization problem. This translates into that if a patient's drug history or medical record has a diagnosis for type 2 diabetes, a prior authorization will not trigger at the pharmacy. A couple of other updates are outlined in the box to the left. So now we're going to switch to Medicare. You can see that 3 plans highlighted in green currently have preferred coverage for tirzepatide. Oftentimes, patients with commercial plans are still not able to afford their medications. Tirzepatide does have a copay card that takes off a maximum of $150 per month and reduces their copay to $25. Unfortunately, the program for patients that do not have tirzepatide coverage expired in June. However, I question its utility, as many of my patients would not have found this program useful, given that they would still be looking at well over a $700 per month out-of-pocket expense. A key exception that I want to cover is in regards to Lilly Cares. I often use it for my patients with Medicare Part D on dulaglutide. The exception here is tirzepatide is not a covered drug on Lilly Cares. So it's unlikely that any of our Medicare Part D patients with high deductibles or that do not have tirzepatide listed as a preferred drug will be able to afford or receive this medication. All right, so to wrap up, who is the ideal patient at this time? For me, it's my patients with type 2 diabetes whose A1C is above goal, with current treatment of one of the more potent GLPs at max dose that are still in need of weight loss, despite continued efforts on lifestyle, would be one of the first patients I would consider using tirzepatide in. I view tirzepatide as an opportunity for these types of patients to get incentivized again. And just like when I use CGMs in this capacity, it's amazing what patients can do when they get a second win of confidence and empowerment. Thinking from the cardiovascular side, perhaps patients with low cardiovascular risk and or that are on an SGLT2 might benefit from tirzepatide. But in the end, it all comes down to individualized care. Now switching gears to another drug class for a moment, I want to take a few minutes to address SGLT2 renal dosing, as it's a bit complex. You are all very familiar with this dosing. We start SGLT2s at initial doses listed here, and if patient is tolerating and requires more glycemic control, we increase to the max dose. Prior to increasing the dose, it's important to always remember to balance benefits, glycemic control, versus risk of increased dose, such as hypotension, increased urinary frequency, renal or volume status, or infections. On the right, these GFR cutoffs listed are when these meds are no longer going to work to lower glucose. Why? As GFR decreases, the amount of glucose delivered to the proximal tubule decreases. Thus, the glucosuric efficacy declines, in line with the decline in GFR. What is important to recognize is often patients with type 2 diabetes will still be on these drugs at GFRs below these box cutoffs, which is what we're going to talk about next. This occurs when dapagliflozin or empagliflozin are being used in patients with type 2 diabetes for non-diabetes indications. My hope is that this slide I created will help you keep the dosing and GFR ranges clear in your mind for these two drugs when being used for indications of chronic kidney disease or heart failure. Starting with the box on the left, dapagliflozin has labeled dosing in CKD and HFrEF, heart failure with reduced ejection fraction. Patients can be started or continued on dapagliflozin 10 milligrams daily, even when their GFR is in the range of 25 to 45. If a patient's GFR drops below 25, they can be continued on the 10 milligram dose as long as they've previously been on this drug. Now let's move to the box on the right, empagliflozin, has labeled dosing only in heart failure, both in HFrEF and HFpEF, heart failure with preserved ejection fraction. and has clinical data via the EMPA kidney trial, which has been submitted to the FDA for approval for the third indication of CKD. In patients with heart failure, they can be started or continued on empagliflozin 10 milligrams daily when their GFR is in the range of 20 to 29. Again, currently not FDA approved, empagliflozin 10 milligrams has demonstrated positive renal benefits in CKD for patients with GFRs as low as 20. In summary, some common themes. When dapagliflozin and empagliflozin are being used for any of the indications just described, there is one dose across the board, 10 milligrams daily. Dialysis is a contraindication for either. And always with this class, continue monitoring patients' volume status while they're on it. With that, I thank you so much for listening. I hope you found this presentation helpful for your practice, and I hope you have a great day.